Hello, everyone. Today I have on Zoom Sonny Provetto, who is the director of Vermont Center of Responder Wellness, and Mark Gale, who is a retired detective sergeant from Vermont State Police. Sonny, why don't you start? Maybe you can give us a little bit of intro about yourself and also Vermont Center of Responder Wellness and the work that you guys are doing.
Sure, thank you. I'm the director, the clinical director of the Vermont Center for Responder Wellness. It's a full-service mental health clinic that serves first responders not only in Vermont but also across the country. We also have collaborations with Trauma Aid Europe, the University of Northumbria in the UK, and as well as Dr. Melise and from Stanford. So the reality of my interest in the Neurosmart is that as a clinician who treats trauma, I'm always interested in the activation of the sympathetic nervous system. We know that trauma memories are stored dysfunctionally, and we know that when we guide people into accessing trauma memories, we can see the physical signs of trauma, anxiety, hypervigilance, sleep disturbances. And so we know that there is a change in physiology just living with trauma. And then more of an activation when you're trying to treat trauma. And we should not be afraid of activating our clients or looking at activation as something that's negative. Activation is a sign or a symbol of somebody who is actually accessing a traumatic memory. And the reason why it's a traumatic memory is because the memory is stuck or still contains the level of emotion that was understood at the time something happened. And the reason why post-traumatic stress is so harmful is because the person still experiences the same emotional distress that happened in the past, now experiencing it in the present. So Neurosmart came as a device that could measure the sympathetic branch or the activation of the autonomic nervous system. I get very interested in it from a clinical perspective, and more importantly, directed towards the acute stress adaptive protocol, something that we created here at the center to treat first responder mental health.
Yes. Now, I wanted to go ahead. I wanted to ask about your protocol next and
Okay.
kind of summarize for us.
Yeah. So I'm going to do that now?
Sure, yeah.
Okay, so the ASAP is an EMDR-based intervention that was designed by myself, Mark, and a gentleman by the name of Bob Lucas, who are all retired police officers. It was designed to treat acute stress. And what we noticed when we developed the ASAP, not only is it a critical incident or post-critical incident intervention, but it also can be used proactively to treat the cumulative stress. And the Neurosmart device would be a device that could show us that individuals are living with an elevated level of acute stress, not only, an elevated level of chronic stress.
Right.
So ASAP is 8 different steps. The first 3 steps in the ASAP actually provides stabilization and grounding and is designed to give the person resources to calm the sympathetic branch of the nervous system. And so what you will see or what we will discuss is the fact that the Neurosmart device actually shows us that when we guide people through mindfulness exercises and we guide people into their breath, that we can see that the sympathetic branch of the nervous system actually downregulates, helping people feel calmer and obviously in the present moment. And then the ASAP, once they assess whether or not the person's nervous system can self-regulate, which is critically important to doing trauma work, once we can see it not only on the ASAP form, because we ask people to give us their subjective unit of distress, but the Neurosmart device shows us through this graph, how activated their sympathetic branch of the nervous system is. And the numbers on the ASAP form, we would hope correlate very well with the Neurosmart graph showing either down regulation or showing sympathetic activation.
So just to summarize, so the first step of this protocol is to ground people and to reduce sympathetic nervous system so they're ready for the process. Is that right? Because the
Exactly
process
right.
does include activation of this traumatic memory, so we want the nervous system to be ready for that. So in the traditional ASAP, you do this and you ask the person how they're feeling, and you do
Exactly.
it by a meditation exercise or breathing. How do you?
Yes.
Yes,
Yes.
we'll get
So
into that. Yeah, go ahead.
there are a series of stabilization and grounding exercises that we teach in the ASAP protocol. They're all grounded in EMDR stabilization and grounding techniques. And
Yep.
these are mindfulness exercises and advanced breathing techniques.
Okay. And how long are we talking in this first portion of grounding?
Moving through steps 1, 2, and 3, which is one is you bring somebody into the present safety.
Right.
Before we ask them to think about anything about trauma, we ask them to notice what level of distress are you experiencing right now.
Yeah.
So from that initial step to installing a positive belief takes about 12 to 15 minutes of developing these resources and installing the resources. So the cool thing about the Neurosmart device is that we see that when we apply the eye movements, or in the ASAP, we're either using eye movements or we're using alternate tapping. When the person is applying the alternate tapping, you can see that there is a down regulation in their nervous system. You can see that it makes them feel calmer, and that bilateral stimulation really increases the tone of the vagal nerve. And what's so exciting about the Neurosmart device is that now we get to see it, right? And more importantly, the person gets to see it, right? And they can see that they can develop skills, right? So the more you practice breath, the more you practice mindfulness, the better your system is, right, at regulating, right? And so now people get to see it. So from a clinical perspective, it's great for the therapist or the interventionist to be able to see the down regulation and that the stabilization and the grounding exercises are working.
Right. And it's, I would guess it's also good for the subject or the patient to see that, right? That they're
Absolutely. And what we're also tapping into, right, is the power of mindfulness and positive psychology, right? When you bring up an image of an adaptive way of thinking about yourself or understanding yourself in a traumatic call, when you bring up a more adaptive way of seeing yourself, and we get you to focus on that positive belief, and then we install the positive belief or strengthen the positive belief by applying, again, the cornerstone of EMDR, right? The bilateral stimulation. When we apply that, we see a dramatic down regulation in the nervous system.
Yeah.
And that's stuff that I don't know has ever been measured.
Yes, that's fantastic. And we will, so just for the audience, so we have done some pilots with them, and basically we will share this data if that's okay, completely anonymized, what that looked like throughout one session of the EMDR, and I think they'll understand better what we're talking about. But for now, let's just continue to talk about the ASAP. So we're grounding the person first, so they're ready, and then what's the next step? What's step 4?
So I think the most dramatic find for me, and I'll just speak from my clinical lens, was in the ASAP. There's an arrow that represents the person's trauma continuum, and in that continuum, we allow the person to step in or to get into the trauma memories of their experiences at any point along the continuum. It's not guided by us where they start or where they drop into the trauma memories. We use the bilateral stimulation. So we use the alternate tapping to increase the communication between the survival brain and the critical thinking brain, to look for what is the focus of the disturbance that they're feeling right now. And in that step 5, in that trauma continuum, the arrow, we see a dramatic spike, right, in activation of the autonomic nervous system. right? So
Right.
just noticing how when we guide the person, and this is the human mind, right? This is the beauty of the human mind, right? It knows how to heal itself. When you guide somebody into the trauma memory networks, there's an instant activation in the nervous system. What that
Yes.
tells us is that the only way that you really do heal trauma is if you can activate those memories. And when you activate the memories, and that's what Neurosmart is telling us, when you activate the memory, then the person is ready to reprocess the information in waking state. So what Neurosmart is telling us is exactly what Francine Shapiro believed. She believed that when we allow ourselves, remember, the number one symptom of trauma is avoidance, but when we allow ourselves to go into the trauma memory, that's when we can actually reprocess the information in a state of being where we feel safe and safe in the company of either the therapist or the peer group, right? And when we feel safe, we see that the Neurosmart device begins to tell us that as we move through the 3 trauma reprocessing boxes, there is this natural downregulation of the initial activation. And we see it not only in the use of the BLS, but also in the use of what we call the cognitive interweave. So when we ask the person in the first trauma reprocessing box, step 5A, when we ask the person to come up with an image that represents the worst part, you can imagine that exercise really identifies the intensity or certain aspects of the trauma memory that the person is now looking at.
Mm-hmm.
And we see that, and we see the downregulation with the BLS. We also see the downregulation when we ask people to take a mindful pause.
Mm-hmm. Mm-hmm.
And then when we move into the next trauma reprocessing box, which is 5B, we ask the person to step back or take a broad angle view of what you're working on and see if you can bring in any new information. And what you see is an uptick
All
in the
right.
activation again. Because what the person is noticing is things that they may not have noticed before, but this new information is the information that creates the healing and the restoring. And we see that because after the initial uptick, there's this slightly slow down regulation once again through the use of the BLS and also by the activation of the adaptive information processing model, right? And that's what the human brain is using. It's using this adaptive information processing to make greater meaning of the trauma experience. When we ask the person to take a mindful pause, you can see there's a slight uptick in the activation again. And then we also ask the person to now give us a subjective level of distress that you may be feeling right now after you've done some trauma processing. And when they go into that subjective level, you can see that they're noticing the distress and they're actually feeling it because not only are they giving it a number, but we can see it on the Neurosmart device that it's an activation again in the nervous system.
Right.
And so every time that we're looking at a SUD, a subjective unit of distress, right, we're trying to take that person from where they are right now, feeling a certain level of distress, and trying to continue to reprocess the trauma till we can get the lowest form of distress that they can feel. And when you go to 5C, which is the last trauma processing box, we ask the person now to take a very detailed look. This is how our logical brain works. Take a very detailed look at why the last level of distress is making that level what it is. What is causing that to still be a level of distress? And the Neurosmart device shows a very sharp uptick again in activation, right? So when we're guiding people in and out of the trauma memory networks, the Neurosmart device is tracking, right? The activation, it's tracking the down regulation, it's tracking the activation, and then the down regulation. And for me, the creator of the ASAP, what I find just so amazing is that the Neurosmart device is an objective marker.
Right.
It is the representation of a nervous system that is either activated, right? A nervous system that's dealing with stress, or it's a nervous system that is reached allostasis or homeostasis, right? Did I get that right?
Yes.
Okay. Okay. And so, for me to just give it a conclusion, right? I would say from a clinical perspective, especially in the world where we understand that PTSD in the first responder professions really is a work-related injury. And when we're talking about work-related injuries, it's really hard sometimes to advocate for somebody to get the help that they need, because it's the subjective understanding of the person and the subjective understanding of the therapist and the subjective understanding of every other mental health professional that is trying to help this person. What the Neurosmart device is telling me as a clinician, right, that there is a constant, or there is an activation. This person has a highly activated sympathetic nervous system, which is a marker of PTSD. It's not a be-all and end-all.
Yeah, no, man.
It's an objective marker that says that this person's nervous system is out of whack.
Yep.
Okay. When we have nervous systems that are like that, I mean, that's ultimately leads somebody to obviously to be unhealthy. Their body is constantly under allostatic load. There's always an increase in blood pressure and tension. And trauma, we know, lives in the body. And a Neurosmart device really shows us how this trauma is operating in somebody's body.
Yeah, that's fascinating. I mean, you touched, I am writing down quotes because I think they're so amazing and important, and I just want to highlight them before we move on to the next topic. But you did say number one symptom of trauma is avoidance, and I think that's really important to highlight, especially in the first responder community, because I think, basically it's very difficult to address trauma because it is by nature avoiding the thing that's hurting you, right? So
Exactly.
if you ask the cop, if you just do a typical debrief, and you might not get any answers or any indication the person is traumatized, because they will completely ignore the topic. Am I right? That's my, I'm not a clinician.
100%.
What I would
100%.
predict from just knowing how how the brain works is they're gonna say they're fine. They're gonna say maybe go to the gym the next day and work out, but it's so important to know that avoidance itself is trauma.
A
So
symptom. Yeah.
yeah, it's symptom of
Sonny,
trauma.
did you want to expound on avoidance things that people do? Because people may just say, I don't want to think about the particular incident, but it goes a lot further than that, correct?
Yeah, so sometimes when we're working with first responders, we want to elicit a wide range of what we believe are pretty typical trauma responses in first responders. And I just took it down the other day. I had it hanging behind me for the last month, and it was a big sticky note of all the trauma responses that people gave us during the 4-day intensive trauma retreat, where this officer wore the Neurosmart device. And what we saw in trauma responses is being a couch potato, right? Needing to just zone out on the couch, dissociate from my friends, my family, maybe binge watch, whatever. I'm not saying that, but what I am saying is that's what we do, right? Like a trauma response is withdrawing from your friends and family and the things you like.
Yeah.
A trauma response is not being able to or lost interest in the things that you used to like, right? When you think about that, what is so cool, the guy or the woman sitting on the couch binging, watching Law and Order all day could look very calm.
Yes.
But if you put the Neurosmart device on them, you might get a completely different picture of what's going on in that person. Now, and I don't know if we've gone this far yet, Melise, but one of the things that would be very interesting is to put it on somebody who we think has more hypoarousal. So somebody who's more dissociative, somebody who depersonalizes a lot of stuff. And that would be another area of clinical attention.
Yes.
That would be,
yeah,
wow, it's like really shining a spotlight on how somebody is doing.
Yeah, I think that's very important that you touched on that. I think I learned this when I was working with some clinicians while I was still at Stanford, that there is a subtype of PTSD, which is dissociative and hyperarousal. Usually, I think people associate PTSD with hyperarousal, which is I
Exactly.
think the more common type. But I think we know that for sure there is a subtype that is hypoarousal, and I'm gonna speculate, and I might be wrong. That this is not just be on all states either, that they might, switch back and
Yeah.
forth in a
Oh,
person. And it's not like everybody's in this category and that category, and there's a wall, and somebody who's hyperaroused will never show a hyperreaction kind of thing. But essentially the nervous system favors one extreme or the other, and is unable to stay in the moment and respond in a measured way to the daily events. It's either I'm just gonna zone out, be a couch potato, and not even do the daily things, or just be adrenaline junkie and go out and be
right.
hyper aroused, or be anger issues, and
Yeah.
everything that comes with hyper arousal. So yeah, that's very important to notice that that's not always hyper, and
Right.
the common response to trauma is withdrawing from daily activities. um so yeah, that's really important. And then the other thing that you said that was really striking is the PTSD is a work-related injury. It's essentially a mental injury, and it should be treated as any other work-related injury, right? But
Exactly.
but there it's hard to maybe define and maybe measure compared to another injury where you have a gunshot wound, or that's
Exactly.
easier to know the healing process. So
Yeah.
so tell us a little bit about, because I think we did talk about, you are in charge of, as a clinician, assessing readiness of cops when they have been involved in a critical incident. So how do you assess them, and how could Neurosmart potentially help in that process after critical?
Yeah, well, now you're talking about, how much time do you have, right? Because one of the things that Mark and I and Bob always have thought about, right, that now that we know so much more about trauma, and now that we have technology helping us with mental health, right? One of the things I thought was like critical, like why couldn't we use the Neurosmart to establish a baseline on men and women who are in these professions, right? So before they get overexposed, and you can even take the 20-year veteran and still develop a baseline, right, before critical incidents, and then see where they are post-critical incident. So the Neurosmart device can be something that can build resiliency in people, because they can see as they move further and further away from their baseline. You need to begin to up your self-care. You need to, enlist your whatever support systems you have, whatever networks you have, whatever you do to keep yourself grounded and connected to people, right? So what happens is we wait too long, or we're
Yeah.
afraid that the stigma keeps us from noticing or doing things, right? And so what we have is we are still at this stage where we have ungodly amounts of first responders killing themselves every year for the last 40 years, and the number hovers around the same all the time, and it's so disheartening. These devices give us the ability to. I just met with an 18-year-old person who's becoming a police officer. And so we would want that person to get a baseline with your device and say, hey, here's your nervous system, right? Before you have 5 years of exposure, or 5 weeks of exposure, or 5 days of exposure, right? Here's your nervous system now. Every year, let's see where you're at, right? Every 6 months, let's see where you're at. And you can develop the device to be a personal device for people. You can develop the device to be used in a larger organizational capacity, right? The reality is just notice what we would have. We would be able to help people, right, who begin to be affected by trauma on the job, and then put in place all of the right resources to keep them healthy. Right, and who should be supporting all this should be the insurance companies who always fight against the workers' comp claims, right?
Right.
We should be putting the money up front because we know that prevention is way less costly, right? And the idea of having a device that can, so here's the bottom line, right? These are stressful jobs,
Yep.
right? And as a clinician, we somehow have to be able to say, Mark Galley has a nervous system that can self-regulate. Mark Galley can go back to work and handle stress.
Yep.
And literally, and I'll say it right now, it's our best guess.
Mm-hmm.
It's
Yes.
our best guess, right? So I think technology can really help us. It can help us stay healthy. It can help us identify people early. This is like cancer treatment. When you catch it early, right,
Yep.
people stand a much better chance of survival, right? So when
Much.
you can catch the nervous system early, that starts to go get out of whack, right? Then
Yeah.
you can start using the interventions to keep people healthy.
Yeah. Yeah, that's so important. And I have experience now with multiple agencies that are using it for either in the academy, so inexperienced cops or cops in training, or in the field training officer training. So in experience, and we have a variety of responses. I can tell you that the range is very big in terms of how activated and how ready these guys are for the job. And we've identified, I mean, Neurosmart, these agencies are identifying folks that seem to be hyperactive and working with them early on and just giving them the education they need about their nervous system and giving them tools to calm down and control their nervous system. So I think it's basically an early intervention tool. And
Yeah.
I'm personally surprised because I worked with this device in non-law enforcement folks in the lab and just like regular people maybe that live with anxiety or they don't live with anxiety, but I've never seen levels in these populations, even with anxious folks that are clinically anxious, that I've seen with some of the police officers.
Right.
So it is very important, I think, to realize the stress of the job is not regular stress, the day-to-day stress that people would experience. And now we have an objective marker. I didn't think that would be the case going into it. I thought, we're all human, threat is threat. And I'm like, yes, threat is threat, and we all have similar type of responses, but the level is much higher that these officers experience. Or
Yeah.
can be higher. Let's just say it can be higher. So it's important to recognize that. It's important to measure it, I think, and to educate cops early
Right.
about the tools they can use to regulate themselves.
Yeah. I think what you're touching on, Melise, is you're touching on a very common conversation that happens with the 20, sometimes 30-year first responder, right? No, I'm good. I'm
Yeah,
good. Right.
yeah,
When you talk about noticing, where people's nervous systems can go if you're in the profession, right? That they're way higher than the general public.
yeah,
That happens because the nervous systems get conditions for survival. And
yeah,
even though the call ends and they go home with their families, the nervous system doesn't reset. And it doesn't reset because of this thing called the hippocampus, right? That the thing that stores the context of the experience, right? And we are not going to get punched in the nose again. And that's basically what the brain is saying.
yeah,
So it elevates the baselines or the set points of people's nervous systems. And some of us are dedicated, spouses and partners and family people and dedicated workers, and we mask. We
yeah,
show up because the optics look good. We show up, but inside we're really falling apart,
yeah,
right?
yeah,
And one of the things that this can bring value to, and if departments made it mandatory once a year, I don't care if you say talk to them or not, but you need to go see a qualified mental health professional who works with our organization, and have at it, right? Like just go see them, right?
yeah.
What that would provide is an opportunity for these seasoned veterans of these professions to be able to talk about, especially if you can see it.
Yeah.
Right? So if you can see it, like, wow, that's me.
Yep.
Right.
Yeah, that's incredible, and that's a very common reaction that we see as well.